of highly active antiretroviral therapy in the mid-1990s, deaths due to HIV have declined substantially. There were 840 deaths among persons with HIV in Georgia during 2020. Deaths among people with HIV were higher in 2020 than in 2019 due to COVID-related deaths. So we want to hear from you as it relates to access to care. In the meantime, I'm going to turn it over to Daniel Driffin.
Thank you, Vivian. So I think Vivian laid out some great slides, specifically showing some of the places of need across our key communities here in Georgia. So throughout this session, we're just going to ask not even really ask questions, we're really going to prompt to really start the conversation. So let's begin with access to care. Specifically, when we think of accessing care for those most impacted by HIV, what are some of the programs or topics that come to mind first? And you can feel free to use your chat feature that's at the bottom of your screen, or feel free to raise your hand and I'll actually call on you. You can unmute and we'll jump into a discussion from there. All right. So the first thing I see is Detox. I am uncertain. Your last name is Andrews. Would you care to tell me a little bit more?
Most of the people who, for number one, I work for Recovery Consultants of Atlanta and the CAD, and we do testing in different sites. And the most important thing is that some of them want to go back into care, but they're out there drinking and drugging. And then they get ready, and then there's no basic detox for them to go to immediately. Or, the public doesn't have enough information to send them to a detox.
Got it. So
that's just one of the things. And plus that another thing is mental health access. Some of them are out there that need mental health inpatient so they can be diagnosed, so they can get on proper med care, so they can take their medications, as prescribed, without having mental health episodes.
Got it. That makes perfect sense. Thank you for that. I really appreciate that. So again, remembering the importance of the intersection of mental health access and substance use programs to assist folks getting back into care immediate. Thank you for that. So I see Kevin saying housing. Kevin, you want to tell me a little bit more?
Sure. Housing seems to be an issue, an ongoing issue that has never been resolved. If you don't have adequate housing, getting into care and staying in the care is put on the back burner. And what's the resolution to the housing crisis for people living with HIV?
Got it. Thank you for that. Again, the most important determinant of health definitely is housing, and we continue to see the impacts of housing on not only people living with HIV, but people vulnerable to HIV. So thank you for lifting that up. Continuing on the conversation with access to care, I see, Jose, you came on camera. Would you like to share anything?
Oh, no, I just turned it back on. But so my name is Jose Garcia. I'll just introduce myself. I'm a patient navigator currently down at Grady Memorial Hospital. I work for their, I'm in the PrEP team. So, pre-exposure prophylaxis. I just got on not too long ago, but of course, I've been helping them out. So I kind of know the ins and outs already. And I just came to learn more and try to gain some more knowledge, to be able to help the patients.
Thank you for joining us. So since you're our captive audience, tell me, what comes to your mind when you think about accessing care for people living with HIV or even vulnerable to HIV?
So definitely, I want to piggyback off what I think the gentleman before me was saying about housing. Definitely, the housing is one of the major issues, because I guess from there, they can have that base and build that foundation to actually start changing their lifestyle. And it's more like a healthy lifestyle, like just, walking your 30 minutes a day, eating healthy. I believe it starts with that as well. Your diet and all of that. So that you can, build your cells.
Got it. Thank you for that. Really, really appreciate it. And we see that you're walking. I'm like, maybe I should stand up and facilitate the rest of the conversation. So thank you for that. Give me the impetus. So continuing on with access to care, what are the things that come to your mind that truly help people get into care immediate? Have you heard of any programs or any, best practices other cities or other organizations may be using that we can further adopt here in the area?
You're asking?
Oh, I'm asking anyone. So anyone can jump in.
Daniel. This is Dr. Virgil. So I'm going to throw out here something that's going to be kind of obvious. I think that when you were asking about access to care too, we have to also talk about actual healthcare and getting healthcare quickly, getting healthcare that's consistent and healthcare that actually addresses the needs of the particular patients. So that means availability of the healthcare, that the healthcare is designed to meet the overall living needs of the patients. I mean, for example, timing, coming to a place for care, and if you're working, affecting the way you can do your job, and creating problems like that. It's something that I hear a lot from the patients. So I wanted to make sure that we threw in there about with access to care, keeping in mind good healthcare. We have some good programs like that around. I've been involved with Atlanta, some of the other ones, Someone Cares, some of the others. So we have some of those here, but it's still really interesting how many individuals I hear from that they still have a difficulty with maintaining the consistency of their healthcare. So I kind of want to throw that out there.
That's excellent. Thank you for bringing that up. I know one of the things that we recently, and we continue to see within our client needs assessment across the Part A programs, are the non-traditional hours. So really ensuring that folks who are living with HIV and, vulnerable to HIV can access organizations, outside of the 9 through 5 window. I think that's really important. Anyone else care to share?
Yes. How you doing, Daniel? This is Avery.
Hey, Avery.
I'm trying to show. There I am. So definitely, great, powerful conversations from everyone that I'm listening to. So for me, when we begin to talk about, we want to maintain good health care. And then you also said about non-traditional hours. I've always advocated for non-traditional hours, but for me, real non-traditional hours. Non-traditional hours, staying open 30 minutes after your clinic automatically closed, is not non-traditional. So let's throw that away. That's number one. Number two, in my former position as a supervisor for outreach, my team went out at 6 p.m. and got off at 1 a.m. in the morning. Let's talk about real non-traditional hours. So those things like that, coupled with adequate care, good case management, and commitment from the consumer will be successful. Here, this is what I know about Atlanta. A lot of individuals who I know personally, they work service sector jobs. So they work over the weekends, they work till 9 o'clock at night, waiting tables, waiting in hotels. So we need something to be able to accommodate them. Not only just mobile units, but we need solid locations where they can go and have accessibility and feel safe. We need a safe place and a safe space for them. We also need committed healthcare workers and providers who are really committed to the cause, not because you're going to get a paycheck or you've been doing this for years. That's over. We've had too many agencies, and we've all seen individuals that have done that for years and years. I do believe there will be a time when the commitment actually speaks to what it is. We want to ensure that individuals who are living with HIV or likely to attract or at high risk for HIV can go and be able to get the proper care that they need. Even you look at all these Sunday brunches that go on throughout the city. Let's talk about partnerships. Partnerships can be with these Sunday brunches, being able to get a mobile unit somewhere over in the parking lot, or being able to talk to the promoter or whomever in order to say, hey, well, can we come once a month on Sundays and we'll get here a shot early, so individuals who want to come in to get treatment, to find out information about PrEP, that it's accessible to them, because we are not doing the job that I know we're qualified to do, as far as with being committed to making sure we have non-traditional hours. Now, that's really my take on it. And I didn't feel this way just today. I've always felt that way. I would say I remember the time when Atlanta had a situation where they were open on Saturday, had Morehouse School of Medicine doctors and fellows and everybody's coming over there and helping with the syphilis when there was a great syphilis outbreak. It was syphilis elimination. So that's a plus. Again, like when I worked with my former position and my team was on the mobile unit, and we went everywhere from Palmetto up to Alpharetta within 14 counties. So we did actually do the bridges. We did make sure Fulton Industrial, we were out there not only to pass out condoms, but to pass out information about PrEP and letting them know what's the best time we can reach you and your friends. Because that's what we want to know. Because see, everybody knows somebody who knows something about it. And that's what we want to do. We want to make sure, okay, tell me when your circle comes out. Where do they hang out? Do they hang out under the big tree of MLK? Do they hang out under the big tree of Bankhead? That's where we need to be. Prove that, we want to say that we're the best. We need to prove that we are the best and that we're doing what we say we're going to do. That's my spiel.
Thank you, friend. I really, really appreciate it. I think you brought up a lot of great things that we have to remember, especially around collaboration. I know, we're here tonight to discuss HIV, specifically for people living with HIV or vulnerable. But, we're having the same conversation, especially as we respond to the monkeypox outbreak. And it just reminds us to bring more people together to touch more folks. So within the chat box, I saw Bailey King say, in our more rural areas, transportation is always one of the highest rated needs identified by both patients and staff. Bailey, would you like to add anything else?
I was mostly speaking towards, I'm with Aid Atlanta, and we do have a location in Noonan. And so that's what I'm hearing mostly from our staff is, yes, there's Uber, yes, there's taxis, but they're expensive and people are coming from across District 4, which is like several counties. It gets really, really expensive. So I write a lot of grants for Aid Atlanta for all of our programs and stuff. So that's one of the number one things I'm hearing out of our Noonan location is please get us some money for transportation to help our patients get to their appointments because they're coming from all over. So I think sometimes it's easy to forget when you're living in, Atlanta, you're in Midtown or, you're downtown or in IPP area, you kind of forget that there are people outside of Atlanta that still need consistent, I really liked, somebody said earlier, consistent access to their care in order to stay healthy and well. So that was mostly what my comment was getting at.
Thank you. Really, really appreciate it. I also see within the chat box, we have Miss Sandra Vincent. Young people are advocating for the normalization of HIV. They want to hear about HIV and health conversations. Miss Sandra, you want to tell us a little bit more if you're able to? Oh, you're muted, friend. Okay.
Hi, just in conversations with young people, and I heard a lot about this when we were having our AAOI sessions, but young folks would like to see the HIV conversation more normalized. I've heard that young folks don't want to go to a quote HIV clinic. They'd much rather go to a clinic that's just a medical facility and not specifically one that is fashioned for the care of individuals living with HIV. And I know that that's a larger conversation, but it is something that a younger demographic is thinking about and they're voicing.
Thank you for that. I really, really appreciate that.
Also, Daniel, may I say something to what Sandra just said?
Absolutely.
So what she says is definitely right. And also in doing health fairs in the community throughout Fulton County, that was one of the challenges. If we just said we were just going there to do HIV testing and HIV, we wouldn't get many people to come and participate. But when we began to partner with other divisions within the county and have blood pressure check, babies can't wait, we have to make it wraparound services. It is so critical because it takes a village, it takes a community, but it takes all of us to have the commitment and know that there's a better, we want to make it better for the next generation. We want to make it better now, but we want to make it ongoingly better and better. And just like Sandra said, if the young folk are talking about it now, that means it's on their mind. They don't want to deal with the stigma. They want it normalized. They just want to go to a clinic, health facility. We don't have to, everything doesn't have to be branded that, because that's what they're talking about. They don't want to go there in this brand. They have the scarlet letter on their head, so to speak. And I've been told that with many support groups that I've facilitated, with the transgender, trans community, with the MSM, and even with cisgender male and female. So that's what they say, hey, we want to come, we want to get tested, but why does that van got to have HIV on it? Why did that van have to have that star on it? I do need a ride to the facility, like Bailey was just saying down in Noonan. We understand that because I have a dear friend in Augusta. They're having the same problems down there in Richmond County, down in Augusta. They're sending vans or mobile units out to pick people up to bring them to their appointments, but it's branded. They don't want all their neighbors to see them hopping in that van. So that can prevent, and it is preventing individuals from accessing care. And even so, I know individuals that live out of Georgia, not out of Georgia, but as far as Augusta and places like that, but they rather come into Atlanta to get care so they don't have to run into somebody who they know or somebody that's gonna say, oh, well, my uncle drives that van and he knows what's up. So they don't want to deal with that. And we really, it's, as Sandra said, it's a bigger conversation, but we have to have the conversation. We still have to have the conversation because just like anything else, it can start off small, but we have to continue and we have to be consistent. In anything that we do, we have to be consistent because consistency is what's going to get the results.
Absolutely. Thank you for that. And I love the way you all are teeing up our next discussion, which will be September the 6th. So not this upcoming Tuesday, but the following Tuesday after Labor Day. And that will be all on HIV stigma. So please, please, please come back for that one and bring a friend or two, okay?
Okay, definitely.
All right. So I saw within the chat, before we go into our next discussion, I wanted to grab Jamila Ely. It says expanding workforce and staff capacity. Jamila, can you tell us a little bit more?
Sure. So just as we talk about everything that everyone mentioned, but just kind of tapping into and expanding on the conversation around just expanding non-traditional hours. Staff capacity is important. We already know in general, public health is underfunded, and we also run into the nuance when we talk about specialty care. And when we do that, oftentimes you run into not having sufficient staff to do the work, and or for a long time, I think we're all aware of that people typically involved in public health are usually in it because they have a passion for it. We have to start looking at ways to ensure that we have more competitive salaries so that people can be maintained and sustained within their positions, career growth and training opportunities that are available. And just ensure we have staff that are qualified, that are sensitive to the community, staff that are relatable, culturally aware in terms of the nuances that we see within the community. And this is inclusive of not just our kind of day-to-day staff, but also clinical and healthcare providers. I think one of the issues we run into is that when we're talking about specialty around HIV, we typically don't talk about the fact that our patients also see other healthcare providers, and you shouldn't just be because you deal in HIV that you are comfortable in talking about issues that are related to our population. And so just ensuring that healthcare providers are properly trained when it comes to engaging with difficult conversations, when it talks about sexual health. And so in terms of just staff capacity in that regard, I think on a broader level, or just in terms of maintaining staff, ensuring that staff are available to do the work and that opportunities are there so that we have staff that are relatable when it comes to our community.
Got it. Thank you so very much. Greatly appreciated. I think you brought up many important things, and I see Bailey is in the chat further in the kudos, especially around burnout within healthcare in general, and then especially when we think about the population that we serve with people impacted by HIV and vulnerable to HIV. So again, thank you. Vivian, can you take us to the next slide?
Sure.
So this is our discussion as we begin to transition into retention in medical care. Again, you see here is a depiction of the HIV care continuum, and it really goes from being diagnosed with HIV ultimately to receiving viral suppression or being undetectable. And again, we know once someone who is living with HIV is undetectable, they will not, share HIV to condomless sexual partners. We also, are mindful that we have more than 20,000 people who are not consistently engaged in HIV care in and around our EMA and across our state. Again, we wanted to have a conversation as we think about retention and re-engagement in HIV care. So what are some of the strategies? What are some of the best practices? Hey, Don, that you've heard as we think about retention and re-engagement in HIV care? And anyone can begin the conversation.
Well, Daniel, I'll start off by saying that I think that one of the big things is that we need to really focus on is the usage of social media. We really need to engage HIV care providers, private providers, as I made the comment earlier about rural providers, also to get them engaging in it as well. Because as we all know, social media now is the way to reach out to people. You could, if you do outreach, for example, social media posts that say you boosted through financially or something, is going to guarantee you're going to get more people that are aware of it and come out to it. So we need to work on, engage, adding the usage of social media to our care continuum itself.
Absolutely. I think that is right on. We continue to see social media in all forms, not just Facebook, Instagram, or Twitter, but definitely TikTok and other shorter messaging applications are crucial. I know we also continue to see the use of even geo-synchronizing dating or community building applications, be ever important, especially bringing folks who are not engaged in care back to care. Anyone else have any other ideas around re-engagement in HIV care?
I did mention in the chat, portal education.
Okay, tell us more.
I myself, living with HIV, when I have some type of emergency, the first thing that I'll do is I'll go to a portal. And also being aging, you know, basically going in my 60s, being in my 60s, right? I found out there's other ailments. So there comes other specialists. So knowing how to work portals gives them a fast track on what's going on. I can tell my pulmonary doctor, you know, this is what's happening with me and HIV. I can tell my rheumatologist what's happening, you know, and give them all the medical things that they need in order to diagnose me properly, so there will be no complications when I'm taking my HIV medication. You know, that I can get the long-term, because there are some long-term effects. You know, after you take it for a while, there's some things that happen. And I know that from a level of experience. So portals are the best way for me to go to work and maybe even use it at a break. Say, listen, I'm getting these constant headaches, or listen, I can't hold down food, or, you know, I can say that, and then get a response on what to do, you know, and I could get up at 7 o'clock or, you know, 8 o'clock at night, but I have some type of response I can look forward to when I go back to the portal for an answer.
Absolutely. Thank you for that. Really, really appreciate it. I think you bring a ever important conversation up, you know, so like one of the ways to access a portal is ensuring you have hardware and like wireless internet, or even, you know, high speed, reliable internet services. So I can do it on my phone. Yeah. Well, you know, even with
the free phone.
Correct.
I could go to the hospital, go to my portal, you know, and bookmark it on my phone, and then whenever I need it, I have it. But see, the one thing about it is the education, you know, especially with people that are working, that are living with HIV.
I see Don hand is up. Don, go ahead, friend.
Yes, thank you. You know, being in the rural area of Augusta and those areas, I think we do face a lot of notifications, and Sandra mentioned about text notifications to, you know, your appointments and so forth and so on. Several of the providers here will not do texting. They will not do notifications due to privacy issues. So that's kind of one of those things we battle with, and we've been trying to do that. I think on the comment just previously about electronics, and I think, Daniel, what you're getting at is, or what I feel you are with that, is that sometimes you either don't have the proper equipment to do that, or you don't understand how to run it. And I find that being older, and when you're first poised with this, you know, it's great to pick up the phone and just talk to somebody, but maybe you can FaceTime. But when you really get into like what we're doing right now, a Zoom meeting, they're lost and they don't know how to do it, and they don't want to know how to do it. And I think what we try to do is do an education point on that. When you get someone in care, when they're coming in as an intake, then part of that is maybe their second time, or preferably their first time, you go over what we offer online, and then we connect that, and we make sure they understand how to work the equipment. If not, we do an education on them.
Absolutely. I think
that's been somewhat helpful.
No, that's the perfect example, you know, ensuring that patients, regardless of age, regardless of background, understand the infrastructure that is there to be the healthiest that they can be. Thank you for that. Kevin, I see your hand is up. Go ahead.
Yes. Don, if you can clarify with me, when you talk about privacy issues with text messages, I don't understand, because even with my providers, I get robocalls reminding me of my appointments. I get live calls for my appointments. And I get text messages, so I'm not understanding.
Well, actually, we aren't either, because it's the provider. It's a selective way of them saying that they don't want to really do that. And they use that as an excuse, frankly, is what we feel here. And so it's not everyone that does it, that we have groups that do that and are very good at it. So it's not, as you just pointed out, it's not really that big of an issue. But there must be some sort of thing there that you have to properly do it. And that's one of the things that we've run into here. So not everyone actively uses that. And it makes it more difficult for people really rely on reminders through the phone and things. And I think that keeps them on track with their thing, with their appointments and so forth.
God, I think
I agree, because I've forgotten appointments and get that call. I'm like, oh, wow, I got an appointment tomorrow. So it helps.
so. I think
For issues like appointments, reminders of appointments, reminders that medications are available, those types of things, and non-specific information, texting is from what I've observed has been fine. It is when it comes down to the more specific discussions of an individual patient's issues, because there has to be a way of making sure that the person that they're talking to is that patient. There's some situations where individuals can like even the social media and stuff, get a hold of people's accounts. And so those are concerns. But general things like appointment reminders, general things like your medications are available, general things like, reminders of where they can go to actually put information that's more specific in those things. So I have not seen a problem with it as it relates to what's related from HIPAA and those kind of things.
This is Reggie. Can I make a comment in reference to that? There is a very, very large problem with that when it comes to the VA and service veterans, because they will not text anything. And so the veteran definitely is out of the loop. They over HIPAA protect.
Yes. I saw Cassandra, and we'll jump back to last name Andrews. Cassandra, go ahead.
So I'm really repeating what others have said, but if we're really serious about retention, then we're going to go the extra step. And there are programs out there that will allow you to leave a voicemail, to text, and to send an email all from your computer. It's just one step, and it does all three. So I think maybe there needs to be some advocacy work on the part of the funders to talk to the agencies about utilizing this. Personal story, I just went through a very serious bout with sciatica, and I'm trying to make $1 out of 55 cents. So I'm working all kinds of hours. And the crazy thing about it is everybody is busy. So if you're getting those text messages and they're reminding you 12 hours out, they're reminding you 3 days out, then you're going to make your appointment and you're not going to forget. So I think this is an underused and very important tool. And as several other individuals stated, you do not have to be client specific anymore than just say your appointment is coming up at such and such time.
Certainly. And I see, before I grab last name Andrews, I see Dr. Thomas is in our chat. Hello, friend. And she added to the conversation with, there are secure text messages services that providers subscribe to deliver text messages for reminders that are HIPAA compliant. Again, I think we just, again, it is a conversation of providing best practices to organizations and providers, who may not know what is available out there towards engagement. Go ahead, our friend from Recovery Consultants.
Oh, Alois.
Alois, thank you, Alois. Okay, go ahead, Alois.
Okay. So number one, before I even received any texts or anything like that, the facility always had a permission. They asked for permission. Can we call, leave a text, leave an email, and you'd have to answer. You know, another thing, just recently, I think it was yesterday, I had made a appointment with my HIV doctor, and I had an eye appointment, and it was at the same time. And if they didn't text me to let me know there was an eye appointment, right, I would not have been able to change it. You know, so yeah, they are, to me, they're very important.
Thank you, friend. Really appreciate it. Continuing with our conversation on re-engagement to HIV care, one of the things that we discuss often is patient navigators or community health workers. That space. I guess the question would be, do you all see patient navigators or community health workers as an important step within the re-engagement to care process? And anyone can chime in.
I am a peer
community.
Peer navigator is peer specialist.
Yeah.
And I have to remain approachable. Nobody's going to approach somebody that is so rigid, right? that they're afraid that they won't get the proper help. But my shared life experience, and also, just being me, especially in the community that I live in, they just, hey, listen, because I actually had a guy I told about was like, 13 years clean. He said, well, can you sneak me to a meeting? And I said, sure, but I try not to let them feel stupid. I try not to let them feel, that I am an authority. I try to let them know that I've been where you are and you can possibly fit where I am.
Got it. Thank you. Anyone else wanted to chime in? So again, the importance of peer navigators, peer specialists, other people living with HIV, serving as retention, re-engagement folks. Where do we see those folks within our continuum of care?
Well, I think that they are a very important part of the continuum of care, because for example, I mean, someone who may not feel comfortable talking to someone, just a general social worker, doctor, provider, or whatever, but if you have a peer navigator who they know is experiencing the same thing that they're going through, they're going to feel more comfortable in talking and discussing whatever their need is with that particular person, as opposed to someone you may have just met at a provider's facility or whatnot or the other. So I think that they're an important part of the care continuum itself.
Got it. Thank you, Tito. Really, really appreciate it. Okay. Don. Don, go ahead, Don.
Sorry. Yes, I'm sorry. I got bumped off from my laptop. I've had to change my phone. On this note, Tito, what we're trying to do in the Augusta area and some of the clinics is do a peer support person, a one-on-one person that perhaps you're available, you volunteer as a patient there, as someone that's been through the ropes, so to speak. And when you have an intake, a case manager has an intake, then the plan is that we will be there. And of course, because of HIPAA laws and everything else, they have to agree to have someone there that would know everything about them basically on their health care and get to know them and help them walk through. And the purpose in that is just not for us or myself as a peer person to just tell my story to them and what happened to me. No, the real purpose is to get to know them and help them. And I would also know when their appointments were, when they were supposed to be there. And I'm the point person that's going to be calling them and saying, I'm just reminding you, now I'll come by and pick you up, or what do we need to do? And did you take your meds and all of that? And so I really think that is where will be a lot of help with continuing care with someone and keeping them in care, and specifically getting them from appointment 1 to appointment 2. Because a lot of times they come in, and one of the things that I've found, at least from listening to several of the clinics here, is they may come in and they walk out and you don't see them again because they don't understand. They think they owe money. They think there's going to be this, and there's the discussion of insurance and all, and it's overwhelming to them basically. And they look and they say, I'm not sick. I'm going to be fine. I don't need this. I've got too many other issues in my life. So it's really, I just think that will help some. And so we're trying to institute that and get it off the ground. But I think that's sort of, that one-on-one is important. So that's what we're doing on our end on that.
Got it.
That's also a Medicaid paid position. You know, you can fill out a form for each and every engagement, and Medicaid will pay you a certain amount per hour that you spend with that client. So if your organization would get with a Medicaid, and maybe CARES or Consumer Network, they will teach you, that if you certify that person, which only takes basically about a week or 2 weeks, that they can get paid to have that position, and it probably wouldn't cost the organization much. So yeah, that's a good idea that you're talking about, but it's already on the platform. But I'm going to the trainings, right? Both of them had that part of their training on how to fill out forms to get paid for the services that you just mentioned.
Okay, thank you for that, Bryn. Really appreciate it.
And Daniel, to add to that particular point, just to let folks know that the Georgia Department of Behavioral Health and Developmental Disabilities actually does the training and certification for the Peer Navigator program here in Georgia that Medicaid does pay for. So you can always find your local community service board to find out about that particular training itself.
Okay, thank you. Thank you for that. Really appreciate that. Vivian, let's transition to this next question. And we have some things in the chat box. So our next question, and this will be one of the questions to begin to wrap us up this evening. It is asking, what are we missing? What are we missing? And who do we need? Let's go back one. Okay. What are we missing? And who do we need to join us in the response to HIV throughout our state? So again, what are we missing and who do we need to join in this response? Go ahead, Don. Don, go ahead.
One of the things that comes up to mind immediately is a group that we've been trying to engage for a while, and it's the primary care physicians in the rural areas, because they see most of the people. And we have found in the outlying, outside of Richmond County and Augusta and Columbia County, there might be 2 physicians in a whole county. And so very often, if they are educated or aware, bringing the awareness that they may have someone that they are treating, or they don't even recognize what the issue is, and they hardly will think of doing an HIV test. That's one of the challenges in rural communities all over the South, especially with that. But we're trying to engage them and do it in such a way that we can at least get them involved, because they would be a source of people who need to get into care, and they need a care that the primary physician really is not equipped to give them. And so that's what we're trying to get started. And we've started a game plan to try to, because of the stigma surrounding HIV, that we are trying to get them to be familiar with test kits that are in-home test kits that can be mailed to someone, picked up, so that they don't have to see anybody really. They can do that. So just that the physicians themselves are aware of even that simple thing. So that's what we're doing, and that's one of the group that I think needs to be pulled into this whole situation.
Our primary care.
And if I
Go ahead,
I was gonna say, if I may add to that, and that's because that's the point I made earlier on the chat. A lot of rural primary care providers, a lot of them, if you actually ask them, will tell you they don't want to deal with it because the care that may be needed with it. So if we can get them educated, but also primary care providers may not have the training to do infectious care treatment. So if we can also, figure out some way to offer that, or get them linked to that, that could also be highly important in the rural areas.
Got it. Thank you. So I also see within the chat, what are some special needs or ways to reach people within our rural communities? I know you just mentioned the rural community. So would you like to add anything on just additional engagement strategies for people across our rural communities? And that could be anyone.
I can just chime in on that again. One of the things we did several years ago was actually engage for ADAP care on the ADAP medicines. And Jay Campbell was really helpful in getting a local pharmacy here in Augusta that has other pharmacies, Barney's pharmacies in the smaller towns, in Jefferson and these smaller towns in the rural areas. So they were able to deliver medicines there. That was also a problem with continuing care because people because of stigmatism, they do not want the medicines mailed to them. They want to pick them up. And then they had a problem getting 40 miles or 50 miles into Augusta to pick the medicine up without someone asking, why are you going to Augusta to get medicine and what is it? So that was one of the things, a hurdle that we were able to kind of help with. And that's one of the things that is an issue in a rural area is medicine delivery.
Got it. Thank you for that. Really appreciate it. Tito, did you want to add anything?
Well, with rural care, it's many things go into the need for that. You have the private providers who may not have the training or don't want to deal with HIV or any infectious disease treatment. Because I'll tell you, many of them, because we hear it. Someone mentioned District 4. That's where I work at. And we also hear a lot of the times when they have infectious disease needs, they just send them to the health department. They don't want to, or they don't have the training for it. So if we can get that, but also, the Aid Atlanta, the lady from Aid Atlanta earlier mentioned talking about transportation, and that's another big issue in rural areas. So I think if we could find some way to loop those in, that could also go a long way in addressing those particular needs as well.
Got it. Really appreciate it. I know one of the conversations in groups of folks we do not routinely include in this conversation are people with different abilities. So, and I'm wondering, how or what are some engagement strategies that we can, promote to bring those communities within our response.
Daniel, I think the best way to do that is to make sure they're at the table. Just one person, make sure that they're at the table, and from there devise a strategy on how to reach the larger population.
Got it. And as soon as I said that, I'm finishing this degree, Lord Jesus. But one of my colleagues, she is a mother of a child with different abilities. And I'm like, why haven't I ever invited her to one of these conversations? So, okay, all right. So that will be the person that I invite for our next discussion on September the 6th, okay? So in the last couple of minutes, what did we miss tonight? What haven't, we brought up that you want to bring up that's on your chest before we tell you again to join us on September the 6th. Actually, Vivian, go back to the first slide so they can take a picture of the advertisement saying September the 6th. Thank you, friend.
And Daniel, real quick, while we're still talking about it, another thing we're missing in the chat box, I've been having a little bit of a side conversation. We're talking about us engaging the school systems. That's another important part that I think we don't necessarily get, because as we all know, one of the highest rates of new transmissions are among the ages of 13 to 24. And engaging school systems can be one of the most, as I said in the chat, one of the most difficult, but still most needed things to do.
Absolutely. And I see Dr. Thompson is included tonight. And Dr. Thompson has a plan for everything. And she actually, when we were doing the Fulton County HIV, she unmuted, so she can take it from here. Go ahead, Dr. Thompson.
Daniel, I don't have a plan for everything, but I probably have opinions about most things. Yeah, so, we worked with the Atlanta Public School System. We worked with the superintendent and with one of the city council members who actually got us a seat on a committee to look at curriculum for the Atlanta Public Schools. And we actually did work with the Atlanta Public Schools to adjudicate different curricula for sexual health. And it was, I think, grades 5 and up, and they did vote to adopt that curriculum. And, I think if you can get an advocate or an ally who is associated with local school systems and try to learn what their challenges are, but, they have to approve curricula. And I think working on the end of being sure the curricula are accurate, and I'll tell you, a lot of the ones we looked at were just simply not accurate. Then, you can actually be helpful. Now, I don't think that is equally easy in all school areas. I think there's significant opposition, but, sometimes it's a drip, drip, drip approach, and you can make small progress that ultimately will get somewhere. Thanks, Daniel.
Absolutely. Thank you, friend. Really appreciate it. All right. So anyone else? We've had some folks join us since the beginning. I see Zena, I see Carrie. Would you guys want to add anything before we wrap up tonight's conversation? Or you can start the discussion on September the 6th when we discuss HIV stigma.
I'll start September the 6th. This is Zena. How y'all doing?
Okay, Zena, I'm gonna hold you through it, friend.
Okay.
I'm Zena.
Zena's so funny. Thank you, Daniel. I'm so sorry for joining you all a little late, but I'm very excited about this conversation. I'm with Zena. I'll hit you all up in September.
Now look, don't threaten me with a good time, okay? So we greatly appreciate you guys. Thank you.
No worries.
Again, tonight is night 1 of a 5-part series, okay? And again, this 5-part series is going towards the development of the next 5 years, specifically our prevention and care integrated care plan. We want to say thank you. This is a snapshot or a picture of all of our emails. We'll actually share these slides at the conclusion of the call tonight, just to spark additional conversation if you think of something in the meantime. Again, we look forward to seeing you September the 6th, which is the Tuesday following next Tuesday, as we dive deeper into HIV stigma. Knowing how important stigma is, and knowing how, knowing that stigma is just the tip of the iceberg as we think about it's stopping folks to access PrEP services and HIV care. So again, we want to say thank you for joining us tonight. We really appreciate it. And we look forward to seeing you all on September the 6th, okay? All right, have a good night. Thank you all.
Good night, everyone.
Good night, everybody.
Good night.
Good night.